Welcome back from our short break. We'll now turn to our next panel and invite those that are presenting from in the room to go ahead and proceed to the podium. Our next panel is Proudly Pro-Vax, Trusted Messengers Speak Up. In this session, we'll explore 3 ways we've turned to trusted messengers to engage communities around vaccination. Our speakers for this session include May Malik from the U.S. Department of Health and Human Services, Rachel Casey from the CDC Foundation, and Denise Octavia Smith from the National Association of Community Health Workers. Okay. And while we're waiting for them to get teed up, we do have one piece of business to come back to. Dr. Jewel Mullen is now in the room. She wanted to record her official vote on the Vaccine Safety Subcommittee report. Dr. Mullen, do you vote for or against the report?
I vote for.
Thank you very much. We are now unanimous. All right. And we'll now proceed to our presentation on Proudly Pro-Vax. May Malik, your slides are up, and see you on the Zoom. You have the floor.
Wonderful. Thank you so much to the committee for having me and to my colleagues from sharing space today. My name is May Malik. I'm the Senior Advisor for the Public Education Campaign and the Acting Deputy Assistant Secretary for both Public Education, or for Public Health, and the current DAS for Public Education. I'm going to be talking a little bit, and sorry, that's at ASPO, a division within HHS. I'm going to be talking about our trusted messenger work as part of HHS's We Can Do This campaign. So we could move over to the next slide. And thank you to whomever is navigating that for me. So We Can Do This is the U.S. Department of Health and Human Services COVID-19 public education campaign. It's a national initiative to increase public confidence in and uptake of COVID-19 vaccines. And it played out during the duration of the public health emergency. The campaign targeted the total market, but made very specific investments in populations that have an increased risk of COVID's worst outcomes, so severe illness, hospitalization, and death. But it's driven by 3 very clear goals, right? We set out to build trust in COVID vaccines, at an unprecedented time and increase uptake. We set out to educate people about the importance of getting vaccinated as soon as they can, so we can actually motivate that change in behavior. And we wanted to ensure that we were educating people about how and where to get vaccinated and pointing people to, the correct resources that they need to find an appointment near them for themselves and their families. Next slide, please. I'm really proud of the very intentional equity work that was done as part of this campaign to reach diverse audiences. We worked with Black, Latino, and AANHPI-owned creative agencies with decades of experience within their communities, and as a result, we were able to produce tens of thousands of culturally competent and linguistically diverse messaging and creative assets. And a large portion of that continues to be publicly available at HHS.gov. And this isn't on the slide, but the numbers speak to this commitment. So going only as far back as November 2020, we've run ads for Black, Latino, and AANHPI audiences in over 300 media markets. So if there's anybody in the room who works in the advertising space, who has placed ads on behalf of the U.S. government, knows that that's quite a feat. So over 300 media markets in nearly 400 local and national print publications and thousands of radio and TV stations. And we worked with nearly 700 Black and Latino and AANHPI community partners. And so these were social service organizations, faith-based orgs, school universities, entities that carried a lot of trust in their communities. Next slide, please. So this is a very high-level snapshot of some of our overall campaign metrics. I thought it was important to really root the conversation and the actual campaign itself before I go into the specifics of our trusted messenger work. But just, we set out to execute a nationwide campaign to arm people with the information that they needed to make decisions, right? To protect, that would protect their health and to answer all the questions that they have about this vaccine, to address this unprecedented virus. And we achieved it in so many measurable ways. A few ways that I wanted to highlight here that are relevant to our discussion is we worked with more than 150 trusted messengers, primarily in the medical space. We launched over 100 activations with 75 influencers, resulting in nearly 4 billion impressions. We organized nearly 3,000 in-person and events and pop-up clinics with organizational partners, leading to nearly 41,000 Americans getting shots in arms. And not relevant to this discussion today, but totally fun. HHS was the first government agency to place ads on Netflix. So if you were binging a program, you might have noticed one of our ads. Next slide, please. So some key findings that led us to sort of the strategic approach to our trusted messenger work. We benefited from because it was a paid campaign, we benefited from a robust ongoing monitoring and evaluation system that really helped us determine a few key things. That people trust professionals who they are closer to, like their own personal or family doctors, their child's pediatrician, and other medical professionals in their family and in their community. And we also learned that having a variety of trusted messengers is the way to ensure that those in target audiences that you are trying to reach are getting information from their preferred sources. So, for example, young adults are more likely to seek out information about COVID from influencers on social media compared to the older adults in their network. So to that end, we developed a strategy to reach people where they are, using the media that they consume and through the voices that they trust at all levels of influence. So from national and community organizational partners, and I believe some of them are in the room today, to influencers on social media, to volunteer ambassadors through our volunteer program, Community Corps, and to local doctors who look like the folks that we set out to reach. Next slide, please. And so in terms of our organizational partners, national partners are, really critical to the work of getting that information out to communities because they get to activate there's the benefit of activating local chapters and affiliates in target communities. So groups like the National PTA and the Boys and Girls Club, we were able to do a lot of really great regional and local work with the audiences that we, intended to reach. With our regional partners, we got to focus on very specific drill down on key audiences and host things like pop-up clinics and virtual webinars, roundtables, an opportunity to share culturally appropriate materials. So with the Cobb Institute, for example, which is listed here, we held a spring and I think also in the fall, a HBCU, historically Black colleges and university, pop-up clinic tour where we brought vaccines to these campuses and got shots in arms. And with Healthy Trucking for America, for example, we brought vaccines to fans at the NASCAR Cup Series Championship in Arizona, for those of you who follow. And community-based partners, to us are those organizations that have even deeper connections to and in language resources for highly vulnerable populations that may not be otherwise be reached with critical vaccine information. So folks like Mujeres Legal Services and Ethnic Minorities of Burma Resource Center was just an incredibly profound partnership that allow us to really, really drill down and bring culturally competent, linguistically diverse resources. I want to note that, every partner implements different tactics, right? It's all down to their expertise and their capacity and their own knowledge of the target audiences. So, we employed a variety of tactics, webinars, panels, town halls, right? Events like this, in-person education, clinics. And the wonderful thing is, if you have communications resources to share, partners are able to implement an integrated marketing approach, so to speak, using, they're able to use our campaign materials, which freed up funding for them, right, to use on other priority activities. Next slide, please. So influencers, I feel like everyone hears this term and has an idea in their head of what an influencer is. It's a really broad term, right? It includes high profile people like artists and athletes and entertainers who are more often than not compensated to promote a message or a product. It also includes just strong social media personalities with loyal followers. And it also includes the credible messenger, right, that we talked about, the family doctor, the pediatrician. So these are all influencers who leverage their real world and online platforms to educate the public. And I think what's really unique, what we found in terms of the uniqueness of working with influencers to promote vaccine confidence is we get to connect with people through the content and programs that they're already watching and they're already following, and they're doing so loyally. We get to build on shared values, not only between the messaging effort and the influencer, but between the messaging effort and the loyal follower base, right? We get to create really unique content through very unique voices to which people have already established meaningful parasocial relationships and who are bound to share and reshare that content over and over. Obviously, if you have the budget for it, paid influencers are fantastic. But again, an influencer doesn't have to be a content creator that you work with to promote a message for a fee, right? An influencer can be an activist with a strong voice online for whom it's less about compensation and more about value alignment. So tapping into your networks is going to be key, especially if you're working with a limited budget. Next slide. Thank you. So community core, I'm a big believer in mobilizing volunteers and coalition building through good old-fashioned organizing. And I think that COVID-19 Community Core is a really perfect example of that. It was launched in April 2021. It's made up of over 17,000 members, including individuals and organizations, big and small, in communities all around the country who joined us at the start, of this launch and committed to being ambassadors of our message, promoters of our message, and to serve as trusted messengers within their own communities and neighborhoods to amplify was, especially at the time, life-saving information related to COVID-19 vaccines. And so that was a beautiful benefit for us, but also the core members were offered the benefit of us organizing events, right, for members to hear from and ask questions of high-level public and nonprofit sector leaders. And members in turn were responding to regular calls to action for engagement and promotion and action. So any new action made on a new vaccine, throughout the entire COVID vaccine journey with new recommendations and guidelines, we were able to mobilize our community core to share social media graphics, sample copy to promote on social, newsletters, posters that they could print out and place in their, it's just a really, really wonderful network that we've managed to grow over the past few years. And I'm really proud of the work. And I appreciate anyone who's in the audience who's been a part of this program. Next slide, please. Local doctors, we identified and trained over 100 diverse doctors from across the country, specifically to answer FAQs about COVID-19 vaccines and to dispel emerging misconceptions through factual research-based messaging. This was a wildly successful program. We provided media training and talking points. We placed these doctors on local TV, radio, and print to talk about vaccines and to address misconceptions, to answer questions, and we earned over 1 billion impressions. The program also netted over 22,000 syndicated airings or postings of nearly 1,000 original stories written by our local doctors since May 2021. Truly, this is a crown jewel of the campaign, and we're very grateful to the dedicated service of these local doctors. Next and final slide, and I appreciate everyone bearing with me. I want to end with some recommendations, and I know we'll get into a little bit of a discussion, but, based on learnings from our trusted messenger work, you heard that everyone's a trusted messenger, right? At all various levels of influence, whether it's a community partner, big or small, a social media personality, a healthcare provider, et cetera. But I think we found that these are like 4 learnings that are applicable to whomever it is that you are engaging to get your critical message out. You've got to be responsive. We didn't just create the content. The content was developed in response, right, to listening to our community partners, asking them to share with us what their clients or beneficiaries or the people that they serve are saying to them, what the pressure points are, what's confusing, what needs dispelling. And we referred to our own research to understand what those questions were and presented these questions to local physicians who then answered them. And they answered them in a variety of ways. We did social, but the most successful was a series of short form videos that were shared on Facebook, Instagram, and Twitter. Number 2, preserve authenticity. It's really critical, especially when it's the U.S. government asking, I think, a outside influencer to share our message, right? You don't want them to, you want them to be unique, right? You want to allow them to use what we provide them, but to create it in their own authentic voice and their own authentic style and medium. So, we provided messaging guidance and ideas, but we encourage folks to use their own unique style. They know their audience best. Not all impressions are equal. This is important because I think people tend to get stuck on digital impressions. Clicked on this link. Influencer engagements is different, right? You're going to measure it differently. That's a whole other conversation, but you don't want to. Influencer engagements have very significant reach, so you can't really compare them to digital impressions, which tend to be smaller. So that's an entirely different, honestly, panel discussion on its own. But you want to think about, measurements for success that are unique to the type of engagement that you are entering into. And then finally, adapt your delivery. And by that, I mean, so if your message is intended to reach a broad audience with the purpose of informing and educating, we have found that animated content, and that doesn't necessarily have to mean animated, but animated is easier to digest, and the attention grabbing elements, bright colors, large fonts, upbeat music, they engage users from the onset, and users watching to completion and receiving the full message with the ad. Influencers are really great for that because they're creative and they get to be unique, and they tend to develop that sort of attention grabbing material. For conversations more like this, or for messaging that is more niche or specific, like guidance to parents about vaccine side effects, as you can see on this slide, among babies and toddlers, an interview style like the one we did with Dr. Murphy, or a QA format with a medical expert, has proven to be successful in engaging viewers to watch through the end. And that's because the audience is likely already actively seeking this type of information on their own time. And so they want to fully understand the message, as they know that it may directly affect them. So I'm going to stop there. I'm looking forward to hearing from my other panel mates, and look forward to any questions you have later on.
Thank you very much, May. Our next presenter is Rachel Casey from the CDC Foundation. Give her a moment to get to the stage.
Okay. Good morning. My name is Rachel Casey. I'm a program officer at the CDC Foundation. Before I begin, I would like to thank the committee for inviting me here to present. Additionally, this project wouldn't have been possible without the federal agencies and partners that contributed to this program's success. So I would also like to thank the CDC, the National Endowment for the Arts, the CDC Museum, my colleagues at the foundation, and finally to the artists and partnering arts and culture organizations who responded to our call to action, became trusted messengers, deployed creative strategies to increase COVID-19 vaccine confidence, and provided a sense of community and social responsibility around vaccination in 21 and 22. Right, so I typically like to begin presentations with a background or summary of how this project came to fruition. Discussions between the National Endowment for the Arts, or NEA, and the CDC began in February of 2021 and continued for several months as agencies discussed moving federal investments in a way that felt innovative, especially within capacity-constrained federal agencies. Several NEA-CDC partnerships were explored before the breakthrough idea came to include the CDC Foundation for a three-way MOU, whereas NEA is to bring its knowledge of the arts field and strong connections to the state art agencies, CDC to bring its investment and public health expertise, and the CDC Foundation to create and manage the program. There were two overarching project goals. The first was to support efforts to increase availability of accurate information about the safety and effectiveness of both COVID-19 and influenza vaccines, essentially by drawing on the strengths of the arts community nationwide to communicate, tailor, and deliver vaccine information that was understandable, personable, and culturally relevant to communities across the United States. The second was to build the capacity of arts and culture organizations through partnerships and resource sharing. This project was to expand the implementation of art-based strategies to address vaccine misinformation, increase vaccine acceptance, and increase vaccine coverage across the country. While the project's target population was the American public, applicants were encouraged to highlight their strategies for reaching young adults, rural communities, and other populations disproportionately impacted by COVID-19. Applicants could utilize any art form in their projects and were encouraged to partner with organizations offering vaccination services. Individual artists who were interested in applying and supporting these efforts were encouraged to look to partner with nonprofit organizations within their community, and applications prioritizing counties and states that had less than 50% of their eligible population vaccinated for COVID-19 were prioritized for the funding. And as you can see, we did end up selecting 30 organizations across 18 states that are listed there on the map. And these organizations focus their projects and programming both in rural and urban communities. They did address all age groups from adolescents to older adults, including several subpopulations of focus, and included all different kinds of art mediums within their projects. To give you a few examples of how these projects were creative as they were diverse, there were narrative film, live theater, podcasts, dance performances, street art, murals, poetry, and quilting. I wanted to highlight a few of the projects from the grantees to give you a few examples of the work that came out. The first one was Hip Hop Public Health Project, which included developing a series of community immunity videos. So these were animated videos, and with this funding, they installed the seventh, and it is a song rap anthology created with youth and informed by stakeholder input, addressing questions around child and teen COVID-19 vaccines, and created family conversations about the critical topic. Another example of a art organization we supported was the St. Louis Story Stitchers in St. Louis, Missouri. They used their own brand of urban storytelling that involved collaborative work in the hip hop music scene and crump dance, videography, photography, podcasting, and produced a challenging body of work for the public to experience on urban canvases, such as city buses and on the airwaves. A couple more examples included Vermilion Cultural Association, which was based out of South Dakota. Their project involved touring several rural areas in Southern Dakota where they would put pop-up events. They would do barn quilting, which is a very traditional and artistic practice. And they would have people engage in community dialogue and conversations around their experiences during the pandemic, and also open dialogue around potential for getting a COVID-19 vaccine. And then I did skip Dad's Garage. On the last slide, Dad's Garage was a comedy improv group. They were based out of Atlanta, Georgia, and very similar, they put on a series of comedy shows across Georgia, both in urban and rural areas, that engaged young adults into conversations and mis and disinformation around COVID-19, while also partnering with clinics to provide on-site vaccination. So I'm going to pause there because I did want to share just two very brief videos or assets that came out of the project.
Hands down, family, Papa, for you.
My loved ones, my friends, and my family.
Friends and family who are really at risk.
I got vaccinated for my students.
The vaccine for me meant my kids get to go back to school.
Porque nos sentimos más seguros. Nos cuidamos nosotros, pero también cuidamos a la gente que está a nuestros alrededores.
Slider, fastball. No, fastball. Change up. Safe! He was out by a mile! You're out of here! You must be out of your mind! Oh, I'm out of my mind? You double out of here! Oh my goodness.
So two brief, very fun, but examples of what the partners had created. The last was a PSA from Dad's Garage that did get shared pretty broadly, based out of the Georgia area. And then the first was a dance theater company based out of LA that had held a series of vaccination events across the country. So. All right. So I did want to mention a little bit of the CDC Foundation support because this was actually the first project that we've ever funded at the foundation that specifically provided grants to art and cultural organizations. We recognized early on in the project that many of these organizations did not have extensive previous experience in public health or programming or managing federal funding. Additionally, due to the constant changing landscape of COVID-19, funded organizations would need to continuously adapt their programming. So it was essential to layer in support for capacity building and technical assistance throughout the project. At the end of the project, communities were inspired to get vaccinated at more than 160 events and performances, and at those events and performances, roughly 768 people received a COVID-19 or seasonal flu vaccine. The estimated potential reach of all content created from these projects, including communication products, campaigns, and events, was roughly 6.5 million people. The success and impact of these projects were also captured through stories and other narrative analysis. And given the significant differences in cultures, strategies, and tactics aimed at encouraging people to get vaccinated, success was not only focused on the number of vaccines administered, but on the ability to build trust and confidence in vaccines, now and in the future. Providing a safe space for people to discuss their questions and concerns was a critical first step in the rollout of any public health initiative, including this one. And while these projects were able to directly support community members receiving COVID-19 and seasonal flu vaccines, their creative outputs undoubtedly reached so many more. As a result of the success of the project, it did inspire an exhibition at the CDC Museum, The Trusted Messengers Building Confidence in COVID-19 Vaccines Through the Art, which featured original art from 6 of the funded organizations. This exhibit came about because early on in the project, as I had mentioned, we had a lot of support from NEA, CDC. I had some colleagues at the National Academy of Sciences who were also interested in how art could be utilized for public health initiatives. And so we collaborated pretty much throughout the project during our monthly cohort calls, where we'd bring organizations together to share about their work, to do peer-to-peer networking and engagement. I would have project partners sit on the calls just to hear some of the dialogue that was going on. One of them happened to be the curator of the CDC Museum. And she was very, very impressed with the assets and just the artist and the organization's commitment to this work. And so she had approached me as the project was wrapping up to see if we would be able to install an exhibit, which we were successful. The exhibition itself features a lot of art, uplifting message around the roles that artists and art organizations played during the pandemic in improving vaccine confidence. And it was originally scheduled to run from December 22 to May of 23, was actually extended up until August after receiving really positive reviews from visitors visiting CDC in the museum. So it was a really great accomplishment, honestly, for the artists to be able to display their work in a public setting and to validate their efforts for what they have contributed to during the pandemic. And finally, lessons learned. So these were some of the main lessons from the project that we had gathered and that I had put and published in an impact report that was released last month. And the first, while data, facts, and information are important, some of the most influential factors in encouraging vaccination is the human-to-human connection or positive peer pressure. So even physicians and other health professionals may need to take off their doctor's hat and use human connections to build trust and encourage vaccine confidence. Another part of this project that really stood out was emphasizing the importance of storytelling, other forms of qualitative evidence versus more quantitative approaches to impact evaluation. This is due, in fact, that many variables do come into play in terms of motivating individuals to get vaccinated, and it really is difficult or nearly impossible to isolate, influence these artistic programs or interventions as the main cause. Furthermore, considering a broad range of indicators for measuring impact of projects is simply beyond getting vaccinated. Some of these indicators that we recommended, including engaging with artistic projects and programs and measuring participants' agency, autonomy, connectedness, and compassion. And finally, art and culture organizations, especially artists, do have meaningful and lasting impact on the community as we witness through this project. And so prioritization and thought should be focused on funding art and public health work in the future, not just for vaccine confidence, but really for any public health initiative. And that is it. Thanks.
Thank you very much, Rachel. Our next presenter in this panel is Denise Octavia Smith from the National Association of Community Health Workers.
Hey, good morning, everyone. I'll make the assumption that you can hear me. Please let me know. Fantastic. I bring you greetings from Hartford, Connecticut. I'm a community health worker, have been for about 25 years, and it's an honor to represent our national membership in all 50 states of promotores, community health representatives from tribal nations, peers, outreach workers, and over 95 different work titles that identify with the values, roles, and leadership of CHWs. I'm going to tell a bit of a story in the hopes that we are considering improvements, deeper integration, and the sustainability of the CHW workforce into pandemic response, and in particular, the way in which community members have understanding, develop readiness, navigate, access vaccines. So next slide, please. If you're not familiar with the National Association, that makes a lot of sense. We're a young organization founded by predominantly CHWs in April 2019. And I came on as the inaugural executive director in November 2019. And so what that means is we've largely grown up in the midst of the COVID-19 pandemic. The overall vision of the organization is to unite CHWs across geography, ethnicity, language, gender, sector, and lived experience, so that this compassionate workforce is able to support communities where they live and serve to achieve health, equity, and social justice. And we're doing lots of different things here. I'm sure the slides will be shared with you, but happy to provide more detail on this slide. Next slide, please. So an important backdrop to understand a CHW's roles during COVID-19 is to really underscore that there is at least 6 decades of evidence of CHW effectiveness across a variety of different chronic disease states. So adult immunization and oral health, diabetes, heart disease and stroke, HIV, AIDS, et cetera. That in addition, we are not paraprofessionals, lay workers. We are, in fact, a workforce. We have our own Department of Labor classification in the Bureau of Labor Statistics. That data is being collected. However, most employers are not consistently using this classification. And so we don't have great data nationally on exactly how many community health workers are in the workforce and where they are working across sectors. It is important to note, however, though, that many states, over 24, have advanced state level policy identifying community health workers and defining them as a profession within the state, talking about their roles, their competency, their scope of work, certification or training requirements or options that are available to the workforce at the state level, and a number of them are advancing CHW's roles in Medicaid. Community health workers as well have their own professional roles and competencies that have been defined by the workforce as is appropriate. All workforces come together to define their own competencies and determine who will train them. And so there are a set of 10 core roles and competencies that CHWs have advanced nationally and in many organizations at the state and local level. And then finally, we were identified as health professionals in the Affordable Care Act. And I point here to 10 years worth of investment in the Patient-Centered Outcomes Research Institute to explore in randomized controlled trials across various different disease states the integration of CHWs and their impact on health and well-being in these various studies. Next slide, please. Now, while that's an important backdrop, and that's sort of the good news in terms of what we have advanced in the profession over the last 6 decades, the reality is that when the COVID-19 pandemic was declared in early March by the prior administration, there were very few individuals and organizations who actually understood CHW's roles in that moment to respond to COVID-19. And so the National Association of CHWs had 3 priority strategies. We were happy that global and U.S. organizations, as those you see in the graphic below, Last Mile Health and Partners in Health and Health Begins and the Community Health Acceleration Partnership, Health Leads, many other organizations endorsed these 3 critical strategies. I just want to take a moment here so that we can talk about what happened as we look at March 2020 and we move across the years since that time. Number 1 was to have states adopt the guidance that was provided by the U.S. Department of Homeland Security, CISA, that classified community health workers as essential critical infrastructure workers. That guidance came out in March 19th of 2020, and that CHW should actually be paid to respond to COVID-19, that they are not volunteers or sort of lay persons, but that they were critical to the infrastructure we needed at that time. That we should mobilize funding to scale the 100 or so CHW networks and associations, professional organizations operating at the local, county, or state level to engage community health workers in contact tracing and a variety of care coordination and training services, remembering at that time that we didn't have a vaccine, but beginning to build the infrastructure of trusted messengers who live like, who look like, who pray like, who share many of the same health beliefs, and who have experienced many of the same barriers as the persons we were trying to engage at that time. And number 3, to recognize community health workers as leaders in COVID-19 response and recovery efforts and around health system transformation more broadly. There was a lot of innovation happening during that time, and our national membership reported to us that instead of being drawn in to those advisories and task forces, instead they were being set aside because people, again, didn't really understand the critical perspectives that CHWs had in that moment to prepare us for the vaccines and the information that would be needed to have broad scale acceptance of public health interventions. Next slide, please. I just want to briefly spotlight here 3 things that the National Association was able to do with our membership, which is, in all 50 states, a number of different tribal nations and territories. Within the first 60 days of the vaccine, we put out a national survey so that we could really understand what were the experiences, what were the concerns and the challenges for CHWs, promotores, and those in community-based organizations with the vaccine. And I don't have time to unpack that here, but I just want to say we missed a number of opportunities. Number 1, CHWs who were not working in health systems were not preferred in the 1A or 1 category. And what that did was it prevented CHWs from having direct experience with receiving a vaccination and being able to share that lived experience with others who had experienced vaccine mistrust, misinformation, or disinformation. Another example is that the National Association of Community Health Workers co-founded an alliance called the Community-Based Workforce Alliance. And within that alliance, we created a playbook for state and local health departments who were receiving dollars from the Centers for Disease Control and others to scale and integrate CHWs into their COVID response, their health education, their vaccine readiness, or their mass vaccination sites, but who did not actually have experience recruiting, hiring, supervising, managing, coordinating these frontline public health workers. And number 3, and this is not directly related to vaccines, but I think this is an important innovation, which was that the National Association was engaged to ensure that we could reach individuals within social vulnerability zip codes when there was an opportunity to distribute free, rapid, at-home COVID-19 antigen tests. We were able to quickly mobilize our membership across thousands of zip codes because we, again, live like and look like many of the individuals and communities in these social vulnerability indexes. And so we were able to reach over 650,000 households within a 1-month period and had 2.5 million visits to the site that we developed for this initiative in 7 different languages. Next slide, please. I want to highlight some important infrastructure and policy levers that were available to public and private institutions. From January 2021, the National Strategy for COVID Response, the April 2021 American Rescue Plan that acknowledged the important role of promotores, community health workers, the tribal CHRs and community-based organizations, the Health Equity COVID-19 Task Force that I'll just highlight 2 priorities, priority 2 and priority 4, priority 1 and priority 4. There was the emphasis on making sure that we were empowering and investing in a community representative workforce, that we were ensuring equity in the delivery of education and creating access to vaccines, and that we were really investing in a representative workforce to increase equitable access to vaccines. So I want to point out some of these important and valuable levers or infrastructure assets that brought prominence to the community health worker profession, even around the area of mental health. So as we saw mental health rates rise with social isolation or sort of the politicization of COVID-19, it was really important that community health workers were recognized as a workforce that could reach different populations that have meaningful discussions, delivering factual information and helping people to navigate to greater access for a vaccine or testing. Next slide, please. What were community health workers doing in the last 3 years of COVID-19? As I mentioned before, we were implementing all 10 of our core roles, and those include not only outreach and health education and navigation, but they also include things like building community capacity, advocacy, conducting research, and making sure that we could draw from that research and develop policies that would improve community health. We were also responding to community violence in that moment, and I just want to recognize the campaign and the way in which community health workers responded to the sharp rise in AAPI hate. The National Association worked with CHWs across the country to ensure that community health workers were aware and knew how to report or respond to AHAPI hate when we saw it. We also were addressing the social drivers of well-being, or some refer to them as the social determinants of health, making sure that as schools were closing, as people were losing their jobs, as food pantries and soup kitchens closed down, as resources that were available in nonprofits were no longer available, community health workers were innovating navigation. They were making sure that relationships were being built to create better referral networks during COVID-19 to address barriers to information and access. It's also important that we were direct response and support for those with many underlying chronic diseases and health conditions. Community health workers historically have worked within chronic disease grant-funded programs from our state or local health departments. So those with underlying health conditions based on a lack of immunization, or those living with HIV, those who were diabetics, or who had a prior heart attack or stroke, or many others, were already connected to CHW interventions, and thus they were receiving much of their COVID-19 information through that established relationship. And then finally, we were building an infrastructure of equity to ready communities for vaccines. And I can certainly talk more about that later. Next slide, please. There were a number of challenges for this profession, and I think it's important for me to really front load those challenges so that when we have our next pandemic, when we need to mobilize this workforce, we don't make some of the same mistakes. The first mistake I have referred to already, which is we had funding dispersed through state and local health departments to scale and strengthen integration of CHWs, but many people did not understand our roles, our competencies, or our capacity. And so the National Association issued a blog in Health Affairs back in May of 2020 to try and clarify. And we were fortunate to have a lot of intake and a lot of interest with subsequent trainings, et cetera, from that blog. We also found that community-based organizations, who are the predominant employer outside of health systems and health plans and FQHCs for community health, they were not able to access many of the funding models and streams, although well-meaning. Many of those funding models had as their title community-based or community health worker, but that did not necessarily mean that those organizations had the capacity or met the eligibility requirements to access that funding. And so many community level, diverse in language and culture, many of those initiatives were not funded and thus did not have the impact that we thought. It was also important to recognize that when you work with frontline workers, that re-traumatizing, proximity to death, to illness, to hospitalization, to the lack of necessary services causes a mental health impact on the front line. We also saw that there were some attempts to engage CHWs and CBOs in NIH innovations, clinical trials, et cetera, for the vaccine. That hesitancy and the lack of relationship building, I think, did a disservice to some of the well-meaning strategies of NIH. And you can read about that in places like CNN Health. Finally, I just want to say some of our best initiatives fell along the wayside simply because they were only given short-term funding. And you can read in places like Kaiser Health News and others where hundreds of community health workers were hired. And then 6 months later, after they had developed relationships and developed strategies that were endorsed by the community, after they had developed trust, many of those had to close their doors because hundreds of CHWs lost funding for their salaries. Next slide, please. My recommendations are a bit long-winded here, so I won't voice over all of them. But what I think is important is to acknowledge that the pandemic showed us that we needed a clinical response to the global COVID-19 pandemic. We needed a public health response to the global COVID-19 pandemic. But we also needed and did not have an infrastructure, funding model, or capacity for a community-based response to the pandemic. And so much of what the National Association has been able to do through our national membership is lift up those voices, lift up the innovations, lift up what did not work or what may not have been scaled or funded due to lack of partnership or lack of infrastructure or lack of policy. We are your partners. CHWs are responding in Hawaii. We've responded to Hurricane Katrina. We will respond to future pandemics. And so we offer our service, our expertise, our competencies as a workforce to improve and eliminate preventable disease and also to improve health and well-being among our most vulnerable. Thank you so much for your time today.
Thank you very much, Ms. Smith, and I want to thank all the members of this panel. I think it's important for us to recognize the different aspects of communication and the importance of trusted messengers, whether it be virtual, face-to-face media, or others, and certainly highlight some opportunities and challenges for us going forward with and without pandemics. Melody Butler, you have a comment?
Thank you all for the presentations. I think it was very important that you all have the ability to highlight the endeavors and achievements your organizations and programs accomplished. In all three presentations, you spoke about your variable successes in improving vaccination rates. Do you foresee that the tools and campaigns you developed and use are going to be successful for this upcoming respiratory season, or are there current obstacles you are concerned about? Thank you.
So May has had to step away. Rachel or Denise, do you have any comments?
My short answer is yes. Sorry, I'm not able to see all the speakers, so I didn't want to interrupt. There were a number of other innovations at the local, state, and national level that I just didn't have time to lift up. But one of them is our vaccine equity repository, all while local, cultural, county, faith-based organizations were developing and fine-tuning their messaging and their campaigns and their strategies. we developed a national repository to collect information. So every social media post, if it was a training, a video, a song, a comic book, outreach materials, we've collected those into a vaccine repository, and those can be searched by language. They can be searched by rural, urban. They can be searched by media type. And so we think that repository will be very valuable as we look to the future.
And I will speak for the CDC Foundation, and to your question with the upcoming increasing confidence, especially in just vaccines in general, that learning through this project with the arts and cultural organizations, they were able to reach their communities in just a very different way than medical professionals and public health institutions were. They specifically, when they would do events or interact with the community, did not frame the event as a vaccine event or a vaccination effort. It was really to encourage people to come out to heal and to do art, which is healing. And then during those events, during those interactions, during having people being able to describe their experiences during the pandemic is when they would make the connection about vaccine messaging and again offer resources. So the response we received from the artists and the art and culture organizations was that the people were relieved that they could just find a safe space to go to that didn't resemble a medical professional or space. And because of that, they had just a lot more positive reaction into just open dialogue. So that was more of the point I was trying to make, that sometimes success is not necessarily the number of vaccines that were administered, but by the ability to create that dialogue in the first place, and to, in the hopes of the future, if another pandemic or were to happen, or for other vaccines, that it could really create that environment moving forward.
Rob Schechter.
Thank you for the presentations. For Rachel Casey, I was wondering about if you could describe the technical assistance resources, how the science, medical and public health folks interacted with the artistic community, either locally or through the foundation.
Yeah, so this, as I mentioned, was the first project the foundation had funded that was working with artists and art and culture organizations. So there was a lot of lessons learned, and when I was assigned the project, I kind of panicked a little bit. I am a public health professional, not an artist by trade. And so when we worked with the artists, they had the same reservations. The video I showed you of Dad's Garage, I wanted to point out that in the beginning, they almost declined the funding because they thought, well, we're just artists, we're not qualified to be able to speak to scientific or vaccine-related messaging. And so really it was just kind of acknowledging, we definitely had resources for the technical assistance capacity building for public health, which is where I would go to CDC. We did a boot camp training, a one-on-one in the beginning of the project to make them all familiar and feel comfortable with vaccine messaging and COVID-19 in general. We did monthly cohort calls with the organizations where they could share out about their projects. We would have open discussion for challenges, successes, connection, networking. As I mentioned, I did have a few contacts at National Academy of Sciences who was very interested in the humanities and how they could co-collaborate. And so the webinar that we produced with them later in the project was a result from the organizational needs assessment I had provided in the beginning of the project to the art organizations. So we were making sure that we were tailoring all of those breakout sessions and technical areas that they were requesting in these more technical webinars between the medical and the science professionals.
Is there time for one? Oh, I was wondering for Denise Octavia Smith, if comment on, I think you mentioned the collective trauma and cumulative trauma. I'm wondering about turnover rate, burnout rate, and training needs to continue these efforts.
Thank you so much for diving a little deeper in that area. I really do appreciate it. I think some of you may remember that the WHO identified 2021 as the year in the health and care worker. And our national association, again, and many local and state organizations partnered with mental health service providers, mental health trainers, to provide and strengthen self-care for community health workers. I want to just emphasize here that, while some of us are working in hospitals and have those unique challenges, some are working through health plans or through the State Department. There are CHWs in El Paso responding right now on the border, and they were responding during that time and addressing the social needs of that time, and also the COVID and infection related needs. So our community has suffered differently. Communities throughout the South and in our major cities experienced many deaths of their patients, and I don't think that we have fully processed all of that trauma. But what it has done is that it has brought additional recognition, one, as mental health, as a health predictor. And so there is now the recognition that frontline workers like community health workers need additional mental health training. They may need that sort of clinical supervision to unpack some of the mental health needs that they're experiencing while they are in dangerous communities, conducting outreach on nights and weekends, or with populations that are at high risk. So we're hoping that our national association will continue to support. We received some support and acknowledgement from SAMHSA and have partnered on a few different initiatives to make sure that state and local training centers for CHWs have a mental health training supports or curriculum available to them. But the short answer is more is needed.
I want to once again thank May Malik, Rachel Casey, and Denise Octavia Smith for your presentations to our committee today. We appreciate all of your efforts, and I am sure we'll be talking about these issues once again, whether pandemic related or otherwise. And you've got to support each other. That's part of the community. It's now turn to our federal agency and liaison member updates. And I think has had some written updates that will be passed on to the committee members. We have a number of our collaborators that will be making verbal presentations. We're going to start with our federal agency members with updates, and we'll start with a report from BARDA by Christine Oshansky.
Hi, good morning, good afternoon, everyone. From BARDA, I'm Christine Oshansky. Just a few highlights I wanted to call out from the written updates that we provided. The first is a filovirus vaccine update, specifically Merck's single-dose Ebola vaccine. That's called Ervebo. It received licensure by the FDA on December 19th, 2019, but in July of this year, the label was expanded to include children down to 12 months of age. Switching gears to anthrax vaccines, on July 20th, 2023, the FDA licensed Emergent Biosolutions Civendus anthrax vaccine for post-exposure prophylaxis of disease following exposure to Bacillus anthracis in individuals 18 to 65 years of age when administered in conjunction with recommended antibacterial drugs. On the pandemic influenza vaccine side, there are several clinical trials that are ongoing, the details of which are in the written update, and these aim to ensure that our nation is prepared to respond to the next influenza pandemic with data on hand. And finally, as part of BARDA's COVID-19 vaccine update, BARDA's been collaborating with the NIH and industry partners to identify immune correlates of protection by the COVID-19 vaccine candidates supported by the U.S. government since 2020. These efforts have included supporting immune assay development and validation, as well as establishment of laboratory testing capability to analyze clinical samples from phase 3 efficacy trials. Now, data from these analyses are critical to understand how well current vaccines may protect against new viral variants that are emerging. They inform and support changes in vaccine strain composition, and they are serving as a starting point for development of next generation COVID-19 vaccines. And that is my update for today. Thank you.
Thank you very much. Next from CDC, Captain Patel.
Good morning. I serve as the Chief Medical Officer for the National Center for Immunization and Respiratory Diseases at CDC, and we have a couple of updates for the committee. First is that we did welcome a new leadership team last month. Dr. Dimitri Daskalakis is serving as the acting center director for NCIRD, and Dr. Amanda Cohn is serving as the acting principal deputy director. And Dr. David Wentworth is now serving as the permanent director for our newly stood up coronavirus and other respiratory diseases division. And then the second update, as many of you are aware, CDC is preparing for the fall and winter respiratory season, and this is a priority for our agency. And we have transitioned our center-led COVID-19 activation to a center-led respiratory virus response activation to include flu and RSV in our activities. And three of our major goals within that response is, number one, to conduct rapid and robust surveillance, including detection of emerging variants. Second is timely communication with partners such as yourselves, providers, and the public. And third is adoption of our new and updated vaccine recommendations, and specifically COVID-19 and flu vaccines, which are now recommended for everyone 6 months and older. And we have new immunization products for RSV. The first is nirsevimab, which is a long-acting monoclonal antibody recommended for all infants less than 8 months. And then a smaller group of infants 8 to 19 months who are at higher risk for RSV are recommended to get nirsevimab in their second RSV season. And then the second product is RSV vaccines for adults 60 and older under shared clinical decision-making. And then tomorrow there will be an ACIP vote for use of RSV vaccines in pregnant people. And look forward to talking more about this tomorrow afternoon. I just wanted to add one comment is I just really appreciated the session that we had, and wanted to also let folks know, of course, that CDC looks at all of our surveillance, vaccination programs, implementation through that health equity lens as well. And that's all for me. Thank you.
Thank you very much. Next, CMS, Mary Beth Hance. All right, looks like she may have had to drop off. Let's move now to FDA. Jay Slater.
Good morning. Still morning. Much of my written report to the advisory committee is repetitive of what you've already heard from BARDA and from CDC, so I'll make quick work of it. On July 20th, FDA approved Cefendis for post-exposure prophylaxis of disease suspected or confirmed to Bacillus anthracis in persons 18 to 65 years of age, when administered in conjunction with recommended antibacterial drugs. On July 27th, FDA approved Ervebo, a vaccine for the prevention of Ebola virus disease. And as you heard already, Ervebo had been approved before for individuals 18 years of age and older since December 2019. This approval was for children 12 months of age through 17 years of age. On August 21st, FDA approved Abrysvo, the first vaccine for use in pregnant individuals to lower the likelihood or severity of lower respiratory tract disease caused by RSV, and it's approved for use at 32 through 36 weeks of gestation of pregnancy. On September 11th, FDA approved and authorized for emergency use updated mRNA COVID-19 vaccines, the 2023 to 2024 formula, to include a monovalent component that corresponds to the Omicron variant XBB.1.5. The mRNA vaccines have been updated with this 2023 to 2024 formula to provide better protection against COVID-19 caused by the Omicron variant. With this approval, Comirnaty was approved to include the 2023-2024 formula and changed to a single dose for individuals 12 years of age and older. Comirnaty was previously approved as a 2-dose series. Approved Spikevax to include the 2023-2024 formula, a change to a single dose for individuals 18 years of age and older, and approval of a single dose for individuals 12 to 17 years of age. Spikevax was previously approved as a 2-dose series for individuals 18 years of age and older. Correspondingly, the EUA for the Moderna COVID-19 vaccine was approved for individuals 6 months through 11 years of age to include the 2023-2024 formula and to lower the age eligibility for receipt of a single dose from 6 years of age to 5 years of age. Additional doses are also authorized for certain immunosuppressed individuals 6 months through 11 years. Authorization for the Pfizer-BioNTech COVID-19 vaccine for emergency use in individuals 6 months through 11 years of age. And finally, as part of the actions on a couple of weeks ago, the bivalent Moderna and Pfizer-BioNTech COVID-19 vaccines are no longer authorized for use in the United States. That ends my report.
Thank you very much. Our next presenter is from HRSA, Brenda Holbrook.
Yes, hi. My name is Commander Brenda Holbrook, and I'm the liaison member for HRSA, representing the Division of Injury Compensation Programs and also the Bureau of Primary Healthcare. So other than the submitted updates, I don't really have anything more to add, although I can highlight for the National Vaccine Injury Compensation Program, they have, as of August 1, 2023, petitioners have filed over 900 claims and over 99 million was awarded to petitioners. And about 31 million was awarded to pay the attorney's fees for costs and compensation and dismissed cases. For the countermeasures injury compensation program, I can just highlight that as of August 1st, 2023, there was over 12,000 claims alleging injuries and deaths from COVID-19. Countermeasures have been filed with the program, and they are working through those claims to determine eligibility for compensation. So for the Bureau of Primary Healthcare, one of the big numbers here on the updated summary is that as of August 1st, there were 23,529,579 COVID-19 vaccine doses have been administered. And that was a huge number I just wanted to point out. But those are the updates for HRSA. If you have any questions, let me know. Thank you.
Thank you very much. Those are very large numbers. Mm-hmm. Next, from NIH is Barbara Mullick on the line. Right. She may have had to drop off. Let's go to VA, Troy Knighton.
Hi, everyone. I hope you can hear and see me. I'm Troy Knighton. I'm trying to turn on my camera, but it's not working. There we go. I'm the National Seasonal Program Manager for flu within the Department of Veterans Affairs and the Veterans Health Administration. So we submitted a written report, but there are a couple of things I wanted to highlight from them. So one program that we've been working on, it's been decades in the making, is data sharing via the Immunization Information Systems, the IIS. So IIS is individual to each state. So as a federal agency, we've had to write agreements with each state individually. And I am happy to say that over 40 states, we have done that. We have, as of now, over 41 are live with automated query and reporting. So that means that not only do we receive information about vaccinations given in community for veterans, we also report out all the veteran vaccinations to each state. And so it's a great advantage. We are still awaiting agreements for 7 states: Alabama, Georgia, Hawaii, Nebraska, New Hampshire, Pennsylvania, and South Carolina. So we hope that we will shore up those last states and have 100% participation with the states on that. For this season, we have been conducting a lot of training and education, especially to providers who administer vaccines. In light of the new RSV vaccine, we have held sessions on that so that our providers can meet and do shared decision making with our veterans on which vaccines to give and the timeliness and time schedule for those adult vaccinations. And then finally, I just want to mention, excuse me, that we have updated all of our clinical guidance statements based on new information that we have received from CDC, and that we continue our community-based vaccinations with over 70,000 providers that we contract with, where veterans can go and have greater access to not only flu and COVID vaccines, but other vaccines. So that's about our 5th year with that program. So that's about it from me. Thank you.
Well, thank you so much, Troy. We miss seeing you in the room. And just to give you a local anecdote, it's really been a huge step forward having access to VA immunization data in the IIS. Really been very helpful in patient care.
Absolutely. And we're hoping to finish it through with those last holdouts. Okay.
Great. Thank you. It's now time just to mention that AHRQ, DOD, Indian Health Service, as well as CMS and NIH have written reports that have been provided to members of the community. We appreciate those. We'll now turn to liaison members with updates, and we'll start with AIM, Claire Hannon.
Good morning. It's Claire Hannon, Executive Director of AIM. We did submit an extensive written report, but I wanted to highlight many things. Our conference will be in December 5th to 7th in Houston, and so we are about to open registration for that, and we have our awards nomination process open for the conference. We celebrated National Immunization Awareness Month by announcing the 2023 Immunization Champion Award winners. Champions were honored in 41 jurisdictions, and each champion received a plaque and has a bio and picture on our website. Some really amazing people. We were just very proud to be a leadership sponsor of the 2023 National Vaccine Law Conference, which was held September 13th to 15th and here in DC. The conference had a special session celebrating the 30-year anniversary of passage of the Vaccines for Children law, and explored current issues related to vaccine law. I just came back from attending the new program manager orientation in Atlanta, and there'll be 2 program manager orientations, September and October, 21 attendees in September, 24 in October. So out of 64 immunization programs, 45 are new program managers since the start of the pandemic going to CDC for their first training. Pretty amazing. And then I wanted to highlight that we have a Reaching for Vaccine Equity podcast that just concluded with the 8th episode. So we've been releasing episodes in a series of time, and these highlight how individuals living with chronic conditions can thrive with vaccinations and healthy behaviors, and it highlights activities from community engagement in communities throughout REACH recipients across the country. There's a lot more in our written update. Thank you.
Thank you. Claire, just to clarify, 40 or more new program managers oriented or being oriented?
That's correct. Since the start of the pandemic, so since early 2020.
Okay. So important to
They're all coming to Atlanta for their first in-person orientation.
Recognizing the turnover again in another segment of our healthcare workforce that is challenged by all of the things that we've talked about previously. Okay, thank you. Next for ARA, Rebecca Coyle.
Good morning. I'm pleased to present just a few highlights from our written report. So I think what's been echoed many times this morning about RSV, we are also very excited to have RSV products in the arsenal. One of the things I just wanted to note, I think from the systems side, there's always, clearly there's the vaccines that are usually entered very quickly and easily, and that seems to be the case as well. As of now, we know that a majority of IIS can accept RSV vaccines into the IIS, so that's very exciting. There is one exception to that I just want to note, and that's related to Nirsevimab. Because this is not a traditional vaccine product and doesn't follow the traditional vaccine product codes, it's not sitting in a system vaccine code set. That means that for the 80% plus of data, it originates outside of the IIS, meaning it's coming from some other data source like VA or a pharmacy system or EHR. It's not being directly keyed into the IIS. That means that those systems also have to make updates to their systems to trigger that message to go from that system to the IIS. So there is a difference there in that most systems for a new vaccine, it just automatically triggers and gets sent to the IIS. So there's a difference there. I think the great thing to note is that, again, much like RSV vaccines, the monoclonal antibody product is also able to be accepted by IIS at this point. So we're really thrilled to see that happening. But it is important to note, like, if it never makes it to the IIS, we won't ever know because it relies on our partners out there. Continuing along that path, I just wanted to note that we are continuing to support the Bridge Access Program. The codes are out there. We're super excited to see that roll out. And then just a fun, I think, fact is I often try and bring up some of the work that we do related to data quality, and that's cleansing addresses and helping to make matches go more smoothly. So just this year alone, there have been over 643 million addresses that have been cleansed across the U.S. using the Smarty program that we have a partnership with in conjunction with CDC. So that concludes my verbal updates. Thank you.
Thank you, Rebecca. Next for APHA, Mitch Rothholz.
Hey, Judge Hopkins. I appreciate being back at talking to NVAC and being involved with that NVAC again. I'm representing the American Pharmacists Association. I've submitted a written report that gives you some of the activities that APHA has been working on. I'd like to highlight a couple of things and then just bring to the attention of NVAC some of the issues that pharmacies are dealing with in this current vaccination season. APHA has been heavily involved with CDC on Vaccine Confidence Project, giving a lot of resources and tools and education to providers on how to address some of the hesitancies and some of the communications needed this coming season as we have the 3 major respiratory vaccines coming into market. We also have been focusing on the new RSV vaccine and helping providers understand how to communicate that and how to work with patients who have questions on that. What I want to spend my time really talking about at this point is that as pharmacies are into the heavy fall vaccination season, implementation is challenging right now. And I think something that NVAC should look at in a future discussion is the process of implementation. So while we're getting the recommendations for vaccines coming out, and you heard even Rebecca talk about some things with the IIS, I think we need to take a look at the process for implementation and how do we help get the systems in place. Because now with social media, the public is aware of these things as soon as ACIP and the director make their recommendation, they're coming into the practices and asking for those vaccines, but the systems aren't ready to go yet. And so we're seeing that now with the new COVID vaccine, where we've got payers who are still in the old system. So when a provider who does happen to have vaccine, and that's another issue that we've got right now, is a lot of providers don't have the vaccine yet, but are getting asked questions about it. But when they go to bill for that, it's still under the old system of where the government provided the vaccine, and not the commercial system where now the insurance plans have to pay for it. So that creates a barrier when patients are ready to get vaccinated. The system's not able to handle it because providers can't risk losing that amount of money from the system. So I think we need to look at what's the timeline for when recommendations are issued to the time when it's ready for implementation in the market. And may need to looking at some recommendations there for giving a little buffer zone for that to occur. But pharmacies are ready when they've got the vaccine. They are handling and talking about co-administration, and we've given them resources and encouragement about the co-administration. And so we're looking forward to a good vaccination season and being productive, working with our partners in the immunization neighborhood. And one other thing, just to make folks aware of, that we've been working with AIM on several different areas of addressing some of the opportunities and some of the collaboration and barriers that public health and pharmacy are facing, and how do we collectively address those issues so that we have increased access and coordination and collaboration going on. Thank you for the opportunity to give you this update.
Thank you very much, Mitch, and glad to have you back with us. Next, for the Public Health Agency of Canada, Erin Henry.
Good morning, everyone. My name is Erin Henry, and I'm the Director General for the Center for Immunization Programs at the Public Health Agency of Canada. I have a few items that I'm going to highlight this morning, but we do have additional information in our written report. So firstly, Canada's National Immunization Technical Advisory Group, NACI, which is your ACIP equivalent, recently released an addendum to the guidance of the use of COVID-19 vaccines in the fall of 2023, following Health Canada's authorization of the first XBB 1.5 containing mRNA COVID-19 vaccine in Canada on September 12th. In the addendum, NACI reaffirmed its July 11th, 2023 recommendation. Just now, it specifically references the XBB 1.5 as well as the authorized age groups. And currently, NACI is evaluating COVID-19 vaccine options, schedules, and considerations for vaccinated and unvaccinated individuals based on age and other risk factors. And we are anticipating guidance at the end of October for this. As well, we have many active working groups on NACI. So we have HPV, pneumo, rabies, hepatitis A, hepatitis B, and herpes zoster at the moment. Next, I'd like to briefly provide an update on the RSV developments in Canada. So in August 2023, Health Canada authorized the first vaccine for RSV for adults 60 years and older. Most jurisdictions in Canada are awaiting Health Canada's authorization of additional RSV vaccines, as well as NACI guidance, which is not expected until 2024. NACI is currently doing an economic analysis of the vaccines that are going to be coming to market. We do have one jurisdiction, Ontario, which is our largest province, which has announced a publicly funded vaccination program for RSV to be launched this fall for long-term care homes, elder care lodges, and for some retirement home residences. In addition, following Health Canada's authorization of Nursivimab this past April, NACI will also be releasing guidance on RSV products to protect infants in early 2024. We did have our Canadian Agency for Drugs and Technologies in Health provide some some interim guidance this summer so that jurisdictions can release their programs later this fall. Influenza season is officially underway in Canada as influenza vaccine deliveries to provinces and territories commenced last week. Provinces and territories will start to vaccinate their high-risk individuals as soon as supply arrives and launch campaigns for the general public, usually in early to mid-October. The majority of jurisdictions across Canada are planning to combine their seasonal influenza and COVID-19 vaccine campaigns in order to preserve health human resource capacity, as we are very strained in this area in Canada, and will co-administer both vaccines whenever possible. And lastly, I'd just like to quickly give a highlight to our Immunization Partnership Fund. This was a fund that was developed in 2016 with the goal of increasing vaccination coverage in Canada. The IPF is an equity and evidence-based grants and contribution program, and the only one of its kind in Canada that funds projects which promotes education and awareness regarding the importance of vaccination. And this year, we will be investing $10 million in organizations working at the national, regional, and local levels, undertaking community-based and community-led projects that seek to increase vaccine confidence and uptake and break down barriers to access, particularly among vulnerable and marginalized populations in Canada. These investments will support the rollout of our fall and winter vaccination campaign against respiratory infections, as well as encourage uptake of catch-up vaccination clinics for those who have fallen behind due to the pandemic.
Thank you very much, Erin. And our final report, verbal report, is from NACCHO, Matt Bobo.
Hello, everyone. NACCHO submitted a report and a couple of highlights from the report to the committee. And a couple of highlights of the report is from July 10th through the 13th, NACCHO hosted its annual conference in Denver this year. It was a sold-out conference, so everyone was excited to get together to talk about immunizations and vaccines. Before the conference, NACCHO hosted a CDC-led Vaccinate with Confidence bootcamp for demonstration sites and work group members. Then NACCHO has also wrapped up the Equipping Local Health Departments to Address Vaccine Hesitancy project in July of 2023. We wrapped up a third cohort of sites that completed a rapid community assessment. Those sites were Santa Cruz, California, Long Beach, California, and Huron County, Ohio. There are links to blog posts about the projects that those individuals did that are posted in the report. We're also working and continue to work for the Partnering for Vaccine Equity project. We've selected a final third cohort that is 19 additional sites. Since the inception of PAVE, NACCHO has done 40 demonstration sites. And so what we will be working on towards the end of the year is wrapping up best practices and lessons learned, and having all the cohorts come together and talk about what went well and what didn't go well. And then we're also working to wrap up our other vaccine confidence work, and so conducting site visits at various demonstration sites across the country to really understand lessons learned from the field. Thank you so much for allowing me to give that update.
Thank you very much, Matt. A written update from ASTO was sent and has been provided to members of the committee. We do not have updates from AHIP or VRPAC at this time. Well, I want to thank everyone for participating in our morning session of our September NVAC meeting. We're going to now adjourn for lunch. We will return at 1:15 Eastern Daylight Time for our next panel, which is Coming Together, Collaborations for Collective Impact. Thank you for participation in our September NVAC meeting, and we will continue our discussions after lunch. Thank you.
Produced by the U.S. Department of Health and Human Services.